Good afternoon, everyone. Thank you for the kind introduction. Jan, also thank you because you gave me also a strange equation to work on. Let me start with explaining the background of my slides. That is a picture of Johnstone Strait. It's a narrow stretch of salt water between northern Vancouver Island and the small islands for the coast of the mainland of British Columbia. The strait has very strong currents and very cold water. It goes from in winter 3 to 4 degrees Celsius, in summer maximum 13 to 14 degrees. Because of that conditions, the strait is blessed with abundant marine life. Otters, seals, sea lions, whales, killer whales, dolphins. In the season, lots and lots of salmon, birds. And that is typically an example of an environment that is extremely sensible to global warming. 1 degree, a difference of 1 degree could completely disturb that system. So I have a few conflicts of interest, but they're not related to this talk. I will use some devices in my talk. The main reason is because they're ready available at my hospital, and that's why I use them. So this is the global view of my lecture. I think the key message this afternoon is that we should try to make our anesthesia greener. This is a slide you've already seen, so you know all about it. I don't have to repeat it. But there are also nowadays secondary goals of anesthesia, like improving patient outcome, working more time efficient, and of course, minimizing waste and increasing sustainability. We will not talk about outcome or efficiency. The 2 other things are the green parts of our anesthesia goals. Sustainability is about the global warming and all those theoretical issues, and you will hear more about them in other lectures. I will focus mainly on waste. How can we avoid waste? By using less, and that's what it's all about in my lecture. First, let me talk about induction. I prefer not to blow and vape. What do I mean by that? It was already explained by Jan. I think we should stop back and mask ventilate a patient while the vaporizer is open. Why is that? Because usually then we have high leakage, because the patient has a beard, because the patient removed his teeth. Also, that is the reason why we select a high fresh gas flow. Because of the leakage, if we then turn on the vaporizer, a part of the sevoflurane goes in the operating room. It's not even scavenged. I don't think any of the personnel in the operating room needs sevoflurane at that moment. Also, and that is the main concern that I have with the blow and vape, is that this is pharmacologically unsound. And lots of times there is still some propofol in the syringe. So if you are concerned that the patient is not deep enough, why don't you give the whole syringe? So now I'm gonna use the simulator developed by Chris Connor. So this is a very typical patient that we have in the operating room, 175 centimeters, 70 kilos. He comes for a minor surgical intervention, and we plan to insert a laryngeal mask. What happens? We give a bolus of 15 micrograms of sufentanil. Oh, shit. Oh.
Ah, hier is het. En dan is dat om die onderste 2 gebruiken.
Oh ja.
Dat is transplantation.
Ja, ik moet terug, hè. Ja. Oké. We give a bolus of 50 micrograms of fentanyl, and then after 2 minutes, we start giving propofol 200 milligrams. You see that immediately, almost immediately, 20 seconds or so, patient loses consciousness. So that is typically the moment that I see lots of colleagues opening the vaporizer, for example, 2%, and with of course, with the high fresh gas flow that we have, 6 liters, 8 liters, some do 10 or 15, because they want to deepen anesthesia before the patient is ready to put in the laryngeal mask. Actually, what happens is there is no deepening because of sevoflurane. We'll see it in the next slide, but we are only waiting for the propofol to reach its peak effect, which is after a little bit over 1 minute. So we are fooling ourselves. There's no need for sevoflurane at that moment. Also, you can see that this is the propofol was given at 2 minutes, 4 minutes, 6 minutes. Anesthesia is still deep enough. So no worries about immediately giving sevoflurane. Also, and this was already explained by André in his lecture, if you give sevoflurane for less than a minute, it will not result in a significant clinical effect that helps you to deepen the patient to accept the laryngeal mask. It just makes no sense. So please don't do it anymore. Then we come to the pièce de résistance, the famous equation that Jan gave me. First of all, 0.5 MAC. 0.5 MAC is not enough. We need 1 MAC to reach our 3 primary goals in 50% of the patients. But what if I use my inhaled anesthetic, or I could also say my intravenous hypnotic? What if I used it only to reach one of the primary goals, and that is unconsciousness? Then I don't need 1 MAC, but I could be safe with, let's say, 0.6 MAC. 0.6 MAC is 2 times MAC awake, and as far as I know, there is no reports on awareness with 2 times MAC awake. Also, and it was already mentioned by Thomas, this is a distribution. So you have people who need 1 MAC, you have people who need more, but there's also people who need less. So it's our job to find out who is where on the graph. Then, of course, I have the other goals that we should accomplish, and therefore I count on synergy. Even a small amount of opioid, for example, in this study, 1.3 nanograms per milliliter of remifentanil reduced the CE50 of sevoflurane and propofol by 50%. So synergy between hypnotics and opioids is very strong. We all know that. We learn it in school, but it's difficult to translate it into clinical practice. And that's when we have some devices that can help us. On the left side of the screen, you have an image of a SmartPil view. This is software developed by Draeger, and it either runs on your ventilator or it runs on a screen connected to your ventilator. And it shows you a dose response surface graph, the visual display of synergy actually, and it also gives you an idea of what will happen in the future if you don't change anything. On the left side you have another image of the simulator developed by Chris Connor. This runs independently of a ventilator. For both these devices, these softwares, and also for Mac, it's important to keep in mind it's about the population. So it can predict what your patient does very good, very exactly, but it can also be way off. So we have to keep that in mind. So when I'm using these devices, it learns me a lot about synergy. So what happens if I don't give remifentanil, but I prefer to give sufentanil? Then we get what I call wobbly synergy. So after a bolus of sufentanil, my anesthesia gets to a very deep level, but then the effect of the sufentanil or the fentanyl, whichever you prefer, wears off. And then you will, of course, you will have to give another bolus to go down again, and another bolus. I don't care about the boluses, I care about these parts. To be safe here and here, what you will have to do is, and then we go back to André's lecture, you will need 0.7 MAC to be sure. I think in that case, your hypnotic agent consumption, and it can be inhaled anesthetics or it can be propofol, will be higher than in the other case where you choose for a continuous infusion of an opioid, preferably remifentanil, but it could also be sufentanil. So if we bring in an EEG monitor, that helps us to see which patient is more sensitive and which is less. Also, it helps us, in that way, it helps us to even more reduce our dose. Apart from that, it is also recommended by a society that Jan is a member of. So if we go below 0.7 MAC, they say you should use an EEG monitor. So by doing so, I think you adhere to the standards, so you're not doing anything wrong. So then comes the final answer to the question, to the equation, how many milliliters of SIVO do I use? Well, there is no clear answer to that. I have to disappoint you. But I can give you a few examples, but it all depends on the type of patient, your anesthesia workstation, cardiac output, patient positioning, Trendelenburg versus anti-Trendelenburg, all these things, they have an influence. So in my case, I used the Zeus from Draeger. Of course, I only started my sevoflurane after intubation, and I immediately selected autocontrol. That is target controlled mode. That is the mode of delivery that has the lowest consumption. I use remifentanil target controlled infusion 2 to 3 nanograms per milliliter, and I use the BIS to control whether my patient is more or less sensitive. In these cases, I both stayed at 0.6 MAC, which resulted in an entitled target of 1.2 and 1.1. You can see that very, very quickly I have immediately consumed 2 milliliters of sevoflurane. And in both cases, after half an hour, my consumption was 5 milliliters. After that, for the rest of the case, my consumption will be around 2 to 3 milliliters per 60 minutes. We have to please keep these numbers in your mind. Because in conclusion, we can administer inhaled anesthetics in a more sustainable way if we use state-of-the-art pharmacological knowledge. 0.6 MAC plus remifentanil, so I changed the equation, Jan, plus SmartPil plus EEG is sustainable, doable, and safe. Because not everyone needs 1 MAC or 0.7 MAC, because synergy reduces our inhaled anesthetic concentration even more, and EEG makes it safe. Then I want to raise some discussion. This is a patient I gave anesthesia to with a total intravenous anesthesia. You may notice that after 32 minutes, my consumption was only 30 milliliters of propofol. She only got remifentanil. If I were to do this patient with intravenous induction and afterwards with volatile anesthetic, for sure I would need 20 milliliters of propofol, that's the content of the small vial, and I think 5 milliliters of sevoflurane. Then, on the other hand, this is a very strong male patient. I gave him anesthesia for 4 hours, and my consumption was 15 milliliters of sevoflurane. Then here we have also a strong woman. She got total intravenous anesthesia, and after 3 hours, I already opened my 6th bottle of 50 milliliters propofol. So, I want to raise the discussion. When there is no clinical reason whatsoever to select one over the other, should we use propofol for shorter cases where we have enough with 2 vials of 20 milliliters or maybe 1 vial of 50 milliliters? And should we select inhaled anesthetics for longer cases? Question mark. No question mark. I think for the sake of sustainability and also for your own comfort, it's better to avoid wobbly synergy. And I think for everyone who is involved in training residents, visualization of drug interaction is very important. Thank you.